Hello, and welcome to the next session of the Ovarian Cancer Online Symposium. I'm Annemette Bull, the Director of Science and Clinical Trials for the Clarity Foundation. Our topic for today's discussion is understanding clinical trials and the ovarian cancer roadmap. I'm thrilled to be joined today by Dr. Thomas Herzog, President of the DoD Foundation, and my colleague, Chrisanne Tallarico, Director of OC Counseling, and I'd like to take a moment for them to introduce themselves.
I'll get started. Thank you so much, Annemette. It's okay if I call you by first name, yes? And Chrisanne, same? Great. Please call me Tom as well. So it's wonderful to be able to do this program. We were just talking as we were getting ready to start of how important clinical trials are, and that's certainly important to me. I'm at the University of Cincinnati Cancer Center and had served as deputy director and also was very involved in the clinical trials office there for cancer. And then in my role as GOG Foundation president, obviously with we have two houses, NRG, we're the G in energy, and then GOG Partners. These all involve clinical trials on a daily basis. So I think it's exciting to talk a little bit about understanding these clinical trials in ovarian cancer, and it's an honor to be here with both of you today.
Absolutely. It's very nice to meet you in this forum. My name is Chrisanne Tallarico. I'm a licensed clinical social worker by training, having gone back to school in order to work with cancer patients and survivors and people affected by cancer. So in my role as the director of OC Counseling at Clarity, it really is what I would consider my life's passion, to be able to offer psychosocial support to ovarian cancer, not just ovarian cancer patients, but anybody affected by ovarian cancer in their life. So excited for our conversation today.
Great. Yeah, and I guess I also can just step in and give a little more background about myself. I am a PhD scientist, trained scientist, and I have worked in cancer research, in the lab for many years, but then 7 years ago joined Clarity and really focused in on understanding ovarian cancer, clinical trials, and standard treatment options. And I'm also just really excited to be here today with the two of you. So before we get started, I want to thank the DoD Foundation for their partnership on this very important online program. The Ovarian Cancer Online Symposium series was developed to provide women, caregivers, and other advocates with impactful information that's personalized for their ovarian cancer journey. So let's get started with Dr. Herzog briefly introducing ovarian cancer clinical trials.
Yes, I think one of the titles or one of the phrases in the title was the ovarian cancer roadmap. And so I'd like to refer to our first slide that we're going to show, looking at what I consider the beginning of the journey for ovarian cancer. And I think there's a lot that goes into this, and you can see a timeline, and obviously a representative journey is just that. It's representative of a group, but it doesn't necessarily dictate what happens for any one patient. But in general, everyone gets diagnosed. Now, often these are based on symptoms, but sometimes people are diagnosed by an incidental finding on an imaging study for something else. Maybe they had a car accident, or there's a number of different conditions that they're getting screened for, and it comes up that there's a mass that's present, or they see actual carcinomatosis where the cancer is spread throughout the abdominal pelvic cavity. And when we think about ovarian cancer, we know that about 75% of women present with advanced stage disease, unfortunately, meaning the disease is in the upper abdomen at the time of diagnosis. And so this is really problematic in terms of the fact that we're starting with very advanced disease. And what happens very often is many of those patients will recur who present with advanced disease. So almost 70% of those patients will recur, of the 3/4 who present with disease in the upper abdomen at the time of diagnosis. So then we make the diagnosis, and then the big decision that the surgeon has to make is really, what do we do in those circumstances? Do we immediately operate, or do we do several rounds of chemotherapy first and then operate later? And there's data on both sides of it, saying they're fairly equal. So we usually make that decision based on whether we think we can get to a complete reduction of the tumor grossly to where we can't see any tumor. We also base it on comorbidities, what type of other problems is the patient having? Would it be better to get the disease burden to a smaller level first? And I think that's sort of the big thing. And then there may be therapy that's given after chemotherapy and surgery, known as maintenance therapy. And then, as I said, unfortunately, a fair number of patients will recur. And then you get into that chemo regimen. And these chemos sometimes can be other drugs. They could be targeted drugs and other things that have come out now. But it's treatment number 2, treatment number 3, treatment number 4, and so forth. And unfortunately, then you start getting to where we're really not having a high likelihood of response at some point. And then certainly that's a discussion between the patient, the treatment team, that needs to occur about whether we want to transition to more supportive care or even hospice in those circumstances. But as I said, that's representative for many patients. Other patients will get treatment in the front line, for example, even though they have advanced disease, and the disease will never come back. So in essence, they're cured. And so we think about 20% of the patients fall into that category. We have a large number now that respond to different treatments for years and years and years. And that's the beauty of clinical trials, and that we're able to generate new medicines and really access tomorrow's medicines today through this mechanism of clinical trials. And that's really what we're here to talk about today. So I think one of the things that I really wanted to talk about also was the idea of, different types of trials. So there's, we label them into phases. So you'll hear phase 1 through phase 4, but mostly phase 1 through phase 3. So phase 1, what is a phase 1 trial? And I try to simplify it all the way down to maybe one or two, several words. So really, to me, phase 1 is about dosing. It's about finding the right dose for this drug or regimen for the patient. The beauty of phase 1 for a patient to consider is that these are usually the newest things out, the newest mechanisms of action. And so that's exciting because it's a drug that is heretofore not been used in cancer. And so just maybe this is a home run. And that we all know in our field, patients that have gone on to some of these very early phase 1 trials happen to be at an adequate dose, and they had that home run. They had an amazing response when we thought that there was very low likelihood that they would respond to anything else. There are problems with phase 1, though, in the sense of the likelihood of that being a home run is low. And we have to be realistic about that, because the patient may not even be at the right dose. They may be, we started a very low dose and we raised those up. There's different ways of doing that. You can start in groups of 3 and you look to see if there was tolerance of all 3 or at least 2 of them, then you move it up. And if it's just one had problems, then you expand that in to see if there needs to be more patients put into that dose to see if that is indeed the maximally tolerated dose. So that's what we really try to find out with a phase 1 study. The other thing about a phase 1 is that it's not necessarily married to any specific disease type. So you have to remember that as well. So what is a phase 2? Phase 2 is about activity. And usually that activity is in a specific disease type now. So, for example, ovarian cancer. We would want to know then if indeed this particular drug seems to be promising in phase 1. We can do expansions to look at efficacy as well, which sometimes helps us understand whether the disease or the drug should be placed into ovarian cancer or pancreatic cancer or breast cancer or colorectal cancer, lung cancer, and so forth. And I think that that's where we can take that dose finding, and we get to the right dose, and then you can add maybe 20 or 30 more patients of a certain group and see if it's promising. Sort of a phase 1, phase 2, right? Yeah.
Yeah, it's in the phase 1, yeah. Mm-hmm.
Yeah. So you can do that expansion, but then you could also just say, well, we did our study and we think because of the mechanism of action and the fact that we had, say, 3 or 4 patients and 2 of them responded, we think we should do a phase 2 in ovarian cancer. And so the size of that type of study would be smaller, right? It would be usually in the neighborhood of, say 30 to 100 patients, where we don't randomize, we just place them onto that study. Now, you can also do a randomized phase 2. Those tend to be a little bit bigger, approximately 80 or so in each arm. But that's sort of where we are. Phase 2, we're looking for activity in a specific disease site. And so that's exciting, right? You're having the opportunity to do that. But what everyone wants to know is this going to be better than what I would have gotten off of a trial, right? So phase 3 is about, can you beat the standard of care? Is it better than what we're currently doing? And that's what a phase 3 trial does. And what's one of the key elements of that?
The randomization. You basically split the people that enroll in the trial into several groups, because you do need to compare this new experimental treatment to the best standard of care that we currently know.
Yeah, and we do that to eliminate bias, right? Because we're all excited and we're all cheerleaders for these new drugs, even the investigators. So we have to be careful with some endpoints that can be somewhat subjective, such as progression-free survival, because when do you do the scans? What if you just chose which patients you wanted to put in, and you put all your best patients into the new experimental arm? It would probably look better. If you put all your healthier patients into that, they would probably do better for longer, tolerate the drug for longer, and so forth. So that's
the term blinded, that we also sometimes explain. Yeah. So it is, a lot of times the phase 3 trials will be blinded. So the patient and the treating physician will not actually know which arm the patient is on.
That's right. Because they'll often give a placebo. So you'll get a injection or a pill that will, you hopefully can't tell the difference. We can often tell because of side effects, which is another issue. But the phase 3 is all,
because the placebo piece is not, it's sometimes it's given in addition to the best standard. People will receive treatment if they are on a treatment trial, a phase 3 treatment trial. It's not that you only get placebo. I think that is a concern that sometimes comes up, and people are worried that they risk to enroll on a clinical trial and actually just get placebo. So I don't know if you can explain that a little more in detail.
Yeah, I think that's a really important point, Anna. And the reason is that's one, I was going to talk about some of the barriers of why people won't go on these. Phase 1, I kind of addressed a little bit. Phase 2 is fairly straightforward. You're going to get the drug. If you're interested in that drug, you go on and you have to consent to get on the trial, and that's the way it goes. Phase 3 gets tricky, right? Because I have patients that go, well, I'll go on the trial, and then if I'm randomized to the arm that I like, then I'll stay on it. No, because that undermines the integrity of the trial. The other one is, well, will I be treated as well as if I didn't go on the trial? And the answer is yes, because you're going to generally get standard of care therapy, and it's often plus this experimental agent. Sometimes it's instead, but if that's the case, we usually have pretty strong evidence that it's at least as good as standard of care, and we want to show that in a bigger trial for registration. Chris Ann, one question. When you think about randomization, there's a lack of control, right? So the patient loses control. How does that influence their stress and thinking about clinical trials?
I think it really depends on the type of patient we're talking about, right? Sometimes people go into an ovarian cancer diagnosis being very risk averse. And then if they've had a few different treatments not work out for them, they may actually become more, their tolerance for risk, their appetite for risk may actually increase, right? Because they're looking for the thing that will work. And so I wouldn't make any assumptions right off the bat. I think it really does depend on not just the patient, but also the context of what they've experienced so far with the ovarian cancer diagnosis. And I guess I do have one other question about phase 3 trials. Are the outcomes only based on progression-free survival, or would it be considered better if there's more tolerability, but the same progression-free survival?
Yeah, so you could design a trial that looks at safety and tolerability. Those are a little bit more difficult to do, and you see most of the approvals are based on efficacy endpoints. In other words, how active the drug is against the tumor. But you could use other endpoints. Some studies we use overall survival, or we use progression-free and overall, or you'll see dual endpoints with overall response and progression-free survival. So there's a lot of different endpoints, and we could probably spend the next hour talking about selection of endpoints, but we won't do that. I mentioned phase 4, and phase 4, just to wrap it up, is those are post-marketing studies to hone in on an indication or to look at a safety signal or something like that that may be required by the FDA or regulatory authorities, or the company may be trying to expand their label, a small expansion of it. So those are done in that setting.
So first of all, Clarity does have a lot of resources that are available on our website. General information about terms that you can encounter when you have an ovarian cancer diagnosis, and also actually quite some general information about clinical trials, like we just covered. But we do also have more specific information related to the clinical situation that you encounter about, like, newly diagnosed patients, about the situation where you're looking for maintenance treatment, or for people that are experiencing a platinum-sensitive or platinum-resistant recurrence. So on our website, we do show standard treatment options that are available for these different situations, and also we list available late-stage clinical trials. That's mostly the phase 3 clinical trials that are currently active in the United States. But Clarity also offer more like personalized, scientific support. And the way we do that is that we invite people to contact us, and then we can actually have one-on-one, like basically personal consultations by phone. And we can cover different subjects in these types of conversations, questions that patients have. But they very often could, be about the tumor biomarker test results, explaining those, and of course about standard treatment options and also clinical trials that may be available for the patient-specific situation. Finding a clinical trial can be really difficult, and particularly for women that are not receiving care in a large institution where these trials are already available. I do speak to people that have tried themselves to go onto clinicaltrials.gov and look for a trial, and that can be quite overwhelming. To really pinpoint what could work for me, what is a good fit for me. So what Clarity has done is that we have actually created ovarian cancer specific trial finder, and it's available on our website. It's freely available. Everyone can use it and find it on our website. So the way we do this trial is that we pull in all the trials that enroll women with ovarian cancer from clinicaltrials.gov. So that is, of course, all the trials, the phase 2 or 3 trials that are only for ovarian cancer, but it is also all the early stage phase 1 trials that allow all kinds of cancers. And when a new trial comes out and starts becoming available, we really read that trial document very carefully, and we pay specific attention to the eligibility criteria. And then we enter the trial into our clinical trial database based on this eligibility criteria. And that allows us to actually search our clinical trial database based on these different types of eligibility criteria. That can be, some trials only allow women that are platinum sensitive, or some trials require that you may have a specific genetic alteration found in your tumor to be eligible. So we enter all that information. And this actually allows us, when we have these conversations with patients that are interested in our help, to do a personalized clinical trial search. So in advance of having these consultations, we do ask people to share their records. And we do that because then we actually can incorporate the prior treatment history, the tumor biomarker test results, and also their scan report results into this trial search. The more information we feed into the trial search, the more specific the trial output will be. And we can really tailor the search to what the patient is interested in. Is the patient interested in looking at trials in a specific location, or would they like an immunotherapy trial, or search for a trial with a new drug that's an antibody drug conjugate? We can really tailor it kind of according to what the patient would like. And finally, we do spend quite some time also following, the research, and we pay a lot of attention when results from clinical trials are presented at the scientific meetings or in publications. So we actually also incorporate this result into our clinical trials database. And when possible, we link the results from trials to active clinical trials to just provide as much information as possible about the trials that are currently available. So that's kind of, that's our trial finder.
Incredibly valuable resource for patients, because trying to do this on your own is daunting at the least. I think what you brought up too, in terms of there's so many more filters now for trials, lines of therapy, what the cell type is under the microscope for ovarian cancer, for example, and you hit on it, the molecular signature for these. And it's not just BRCA mutations or even homologous recombination or HRD, but we're getting into now looking at different trials that demand a certain HLA type and then more rare mutation. And so you get these filters that are built in, and multiple filters in some studies, which is great because we're getting to very truly precision medicine and personalized care, but it creates a lot of stress of finding the right trial at the right time. You're
and it's not always the trial is available where you're already being treated. That's very realistic, that you may sometimes, if you want a certain trial, it may also require to travel to another site. Yeah.
Sometimes when I'm talking with participants in our program, they aren't thinking about looking at clinical trials until after they've exhausted their standard treatment options. I'm curious what you both think about that.
I do also encounter that, and that is sometimes sad, and it is a little bit of a common misperception. I think some people think that a clinical trial is kind of the last thing to try once you have exhausted all the standard treatment options. But the problem is that a number of trials, in particular the later stage trials like the phase 3 trials, sometimes limit how many prior therapies you can have to enroll. So that's unfortunate if you really are interested in a trial, and you have already had 4 or 5 treatments, and now you cannot any longer get on that trial. So in general, I think if possible, every time a patient needs to make a treatment decision, it is optimal to try and understand what are standard treatment options and at least later stage clinical trial options that could be available. And then, hopefully make an educated decision about what's right for me at this time. So
yeah, I completely agree with what you just said. And the only thing I'd add on is that remember what we were talking about in terms of phase 1 through phase 3 trials. Remember, phase 3 trials really do offer tomorrow's medicines today, and whether they're going to be successful or not, that's no guarantee they will be, but there's been hundreds of millions of dollars investment into a phase 3 trial. So somebody's betting pretty heavily that that's going to work. Phase 1, not so much, but you do get the newest things, as we said. But if you wait and wait and wait, the only thing you might be eligible for is a phase 1, no longer a phase 2 or a phase 3. So there's opportunity cost of waiting to do a clinical trial, in my opinion, and I would have no hesitancy of putting a loved one onto a phase 3 trial upfront.
Exactly, since also it is typically, it is the best standard of care that the patient will get if they get into the standard arm, so that is a very good point. What we also sometimes experience in Clarity is one thing is to actually identify a trial, but the next steps of finding a site, contacting the site, and starting the whole process of enrolling in a trial can also be really difficult if the patient has to do that all by themselves, which actually is not uncommon, unfortunately. So Clarity more recently has started another program. We call it our second opinion referral support. But we also very much think that can be helpful in the setting of the clinical trials. So what we offer is that we can help identify a gynecologic oncologist in a specific location in the United States if a patient is interested in a second opinion. And Clarity's chief medical and scientific advisor can then reach out on behalf of the patient and facilitate setting up an appointment with this gynecologic oncologist. So we really also think of that as a way that we can help patients that are interested in getting in touch with a clinical trial site. And, we can help basically getting that connection made. So I just want to make that's also another way we may be able to help.
When I hear both of you talk, of course, as a social worker and thinking about the psychological impacts of this, it really just calls for how important it is for people to be able to manage the fear and anxiety around the diagnosis, right? Because it's hard to look forward and to be planning into the future if you're not sure about that future, and there's a lot of uncertainty there. So I wanted to speak a little bit to, Tom had an OC roadmap at the very beginning. Clarity also has an OC roadmap that we use to kind of help us understand psychologically what people are going through the experience. And so hopefully you'll see our slide here. We've essentially broken down the ovarian cancer experience into 4 different phases, the first of which is the crisis of diagnosis. And the idea of this OC roadmap is just to help our patients and our participants orient themselves to where they are in this experience and begin to identify and learn how to understand what they need and get those needs met. So when somebody's recently diagnosed, there is a lot of shock. There's a lot of disbelief. It is really challenging to imagine that this experience is actually happening in one's own life. And we try at that point as much as possible to help people with 2 things. Number 1, help them establish a sense of safety. Are there people in your life that give you a sense of safety? Are there objects in your life? Are there places in your life? Are there practices that give you a sense of safety? And then number 2, stress management. Because of course, to your point, Tom, people could be diagnosed not even having any symptoms, not even thinking that cancer was on their radar, right? And so the sense of disbelief and shock at that point is even more. So from that point, the second phase being coping with treatment, and really practical and logistical concerns take precedence at that point, right? We've got new routines related to medication management, new routines related to treatment. We have to think about work considerations. We might have to think about childcare considerations. So when we're trying to support somebody through this experience and they're in that treatment phase, especially frontline treatment, where this is entirely new to them, we're thinking, how can we help them make balanced decisions? Not decisions just based on fear and not decisions just based on information, but bringing those 2 together to the decision that is most important and most in line with their value system. And then that third phase being transitioning to a new normal. And that can happen after frontline treatment, or sometimes, treatment doesn't stop after frontline treatment, but there is a sense that there's a rhythm to treatment, or that people have kind of they begin to understand or see this pattern to when they're going to feel their best and when they might not feel their best, and they know how to pace themselves a little bit better. At that point, people really start to have these questions about, wow, I'm a changed person. Who am I now and who do I want to be? And often there's a need for more emotional expression. I almost think of it as there's a little bit more physical safety. There's a little bit less uncertainty because they see the pattern of their routine. And it's our job, I think, to help people grieve. Even with the best prognosis, there are some losses through this experience. So we're just trying to help people really understand what they're feeling, talk about what they're feeling, or if talking isn't their strong suit, try to find other ways to express it. And the fourth phase being managing uncertainty and trying to find a balance between how do I be proactive related to my health and at the same time not let fear dictate all of my decisions and dictate all of my decisions, not just around treatment, but also how I spend my time, who I spend my time with, how do I invest in life. And so, our program, the OC counseling program, offers 10 sessions of emotional support over a 6-month period of time. And through those 10 sessions, we're really helping explore this version of the OC roadmap, in terms of how does ovarian cancer affect someone, not just physically, but mentally, emotionally, spiritually, and even socially. So I think it's another good pairing in terms of personalized support.
Absolutely. Yeah. And Chris-Anne, often I speak to a patient the first time when they experience a recurrence. So even though you presented this with like the shock of diagnosis, it still makes sense, to consider OC counseling, even though the patient has gotten in touch with Clarity at a recurrence, right?
Yeah, absolutely. And in fact, we've had people reach out to us after being NED for years, right? No evidence of disease for years, and it's still on their mind. and they want some support. So at any point after an ovarian cancer diagnosis for either the patient or their caregivers, you're welcome to enroll in our programs.
Yeah, I think one of the things that's I've always been surprised at is just how differently this diagnosis can affect people. And as you said, you could have someone who just, they've had the best response and they're maybe cured with advanced disease, and yet they're not living their best life. And so I think that's so helpful to identify that and to get people to think about that. I've had patients who literally have had wasted years of just incredible anxiety and incredible depression because of the disease, and then there's others who've coped seemingly so well. So it's just, I think it's a wonderful thing to offer those sessions to patients. It's such a great resource and so needed.
Yeah, there are a lot of things. One thing I also often hear is that it can be extremely scary to stop treatment. I think that's also one of the transition points that I think you talk about, the idea that you feel that you're actually fighting the disease while you're receiving the treatment, but then you have to stop, and that can be a very, very scary transition, and having to accept that.
It cuts both ways. That's the interesting thing, right? Is it really cuts both ways. You see patients that when you talk to them about maintenance, giving additional treatment, even though they're in what we think is a remission, at least clinically, we know there's likely cells floating around microscopically, which is the idea behind maintenance, to give them some additional therapy. But the point is that some people don't want to be reminded of the fact that they have the disease, and yet other people feel that if they don't do something bad's going to happen, and they don't want to quit their maintenance. And even though there's prescribed, times that we often will come off based on some of the studies. So it's very interesting to look at how different people react to the same question.
Yeah. It is also interesting, like in the medical aspect, right? We're working toward this idea of precision medicine, and we really feel that way too from the psychological perspective, right? It isn't a one size fits all, and it is a give and take, I think, between patients and their physicians around what is going to be the best decision for them, clinical trial wise or otherwise.
Mm-hmm. And then I also think it's extremely helpful that you offer to speak with relatives, like to caregivers. That also can be very helpful at times, both for the patient and for the caregiver, I can imagine.
Yeah, unfortunately and fortunately, right? So understandable. Either party in that situation doesn't often want to share their feelings with the other, right? They think, I'm going to make my husband sad, or the husband thinks, I'm going to bring her down if I tell her how I'm feeling or how scared I am about this. And so we play this lovely intermediary role, not that we close the loop necessarily, but just as a springboard to get those feelings out, talk through what the actual fears are, see if there's some problem solving that can be done, and then be able to set them up to have that conversation.
Exactly. And I feel very fortunate that, like, being part of the scientific conversation, that I have this other resource to offer. And I know in the same way, on occasion we have people that have spoken to me a few years back, and then also later have more questions about science. So we kind of have that interaction going between our programs, and the option to kind of come back.
Absolutely.
Powerful.
Yeah.
Mm-hmm. All right. I don't know, Tom, would you finish off our conversation?
Sure. I think that, if there's any take-home message, that if you can't tell from the passion of the three of us, that we think clinical trials are important, but also mitigating the effects of treatment for ovarian cancer are important. It's just to reemphasize that clinical trials, that platform or that vehicle, is the conduit to knowledge. In other words, we wouldn't be where we are today if we didn't have patients enrolling. And so you may gain something, but there's no promise of that in terms of, a better outcome by going on a clinical trial. I will tell you, society and the women that follow you will have definitely gained. And if I look at when I started doing this, hair wasn't gray and I had more of it. And the median survival for these advanced stage cases for patients with disease outside the pelvis was really in the order of just over 20 some months, under 2 years for sure. And now we look at the median survival for those patients, and it's well over 5 years. And based on, the more recent studies with PARPs, for example, in those with a BRCA mutation, 7-year data shows we may be curing women now with advanced stage. So, it's all based on clinical trials.
Mm-hmm. Yeah.
It's all based on that.
Absolutely. Thank you so much. And thank you for your listeners for taking time to join us for this Ovarian Cancer Online Symposium. The Clary Foundation and the DOG Foundation would also like to thank our commercial supporters for this video series, NovoCure, Verastem, Immunogen, Alchemies, and R-Farm. So if you have questions or you're looking for more information, please visit our website or contact us by phone or by email.